Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Hello, future nurses, and welcome back to another high-yield NCLEX learning session with Stan Coast. Every single day, we tackle 2 to 3 powerful topics that bring you one step closer to your dream result. And today is no exception. Today's focus is on a condition that nurses encounter frequently in clinical practice, venous disorders. From varicose veins to deep vein thrombosis, we are going to break down the pathophysiology, risk factors, nursing management, and most importantly, the NCLEX-style clinical reasoning you need to master this concept. By the end of today's session, you will not only understand how to identify and manage venous complications, but also how to differentiate them from arterial disorders, interpret key diagnostic findings, and apply nursing interventions that save lives and prevent complications. So get your notes ready, stay engaged, and let's make today's lesson another winning step in your nursing journey. Let's begin with venous disorders, followed by our next 2 high-yield topics, each designed to strengthen your clinical judgment and test readiness. Before we move on to the next NCLEX topic, let me share something that could be the game changer in your journey. If you are determined to pass the NCLEX on your very next attempt, the ultimate NCLEX crash course is exactly what you need. This program has already helped more than 100,000 nursing students achieve success. And now, it's your turn. Here is what makes it powerful. Daily interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks and PDF notes for quick revision, a ready-to-use student planner, and detailed NGN question breakdowns in comprehensive lectures. It is not just a course, it's your all-in-one NCLEX toolkit. Simply scan the QR code now or click the link in the description to enroll instantly. You'll unlock free content like PDF notes, practice tests, and NCLEX quizzes, plus access to our Telegram and WhatsApp groups filled with even more free resources to keep you ahead. Let us begin our NCLEX-style journey with an engaging clinical observation question that blends anatomy, physiology, and nursing assessment. A nurse is assisting a middle-aged client onto the examination table and observes several large, tortuous, bluish veins on both lower legs. The nurse carefully reviews the client's health history to identify potential risk factors. The question asks, which factor most strongly predisposes the client to the development of varicose veins? Here are the options. Option A, the client's mother also has varicose veins. Option B, the client has smoked cigarettes for 20 years. Option C, the client was a competitive track athlete in high school. And option D, the client works long hours at a desk as a corporate executive. The correct answer is option A. The client's mother also has varicose veins. Now let us explore why this is the most accurate choice. Varicose veins are dilated, tortuous, and visibly bulging. Superficial veins that arise from venous valve incompetence and venous wall weakness. This leads to chronic venous hypertension and venous stasis. Among all possible risk factors, the most significant non-modifiable one is a positive family history. Genetics play a crucial role by predisposing individuals to congenital structural weaknesses in venous walls and valves. These weaknesses cause improper valve closure, which allows blood to pool due to gravity, resulting in progressive vein dilation and visible varicosities, particularly in the lower extremities where venous return must work against gravity. To elaborate, option A is correct, because having a family history of varicose veins signals a genetic predisposition toward defective venous connective tissue and valve dysfunction. This inherited weakness makes an individual more prone to venous dilation, even when exposed to minor occupational or environmental stressors. In essence, the trait runs in families and significantly increases lifetime risk. On the other hand, option B is incorrect, since cigarette smoking primarily affects arterial circulation by causing vasoconstriction and endothelial damage, leading to conditions like atherosclerosis and peripheral arterial disease. It does not directly contribute to venous valve incompetence or venous hypertension, which are the hallmark mechanisms of varicose vein formation. Moving forward, option C is also incorrect because being a track athlete actually enhances venous health. Regular physical activity strengthens the calf muscle pump mechanism, which promotes venous return and prevents venous stasis. Thus, an athletic lifestyle is protective rather than causative for varicosities. Finally, option D is incorrect, because while a sedentary lifestyle or prolonged sitting may exacerbate existing venous insufficiency by increasing venous pressure, it is considered a modifiable occupational risk rather than the underlying cause. The initiating factor remains hereditary weakness in the venous structure. To summarize this concept with a clinical perspective, varicose veins develop due to failure of venous valves, resulting in retrograde blood flow, venous dilation, and ultimately chronic venous insufficiency. Over time, this may progress to edema, skin pigmentation changes, and even venous ulcers if untreated. And here comes your Stankos pearl. Varicose veins run in families before they run in legs. Genetics lay the foundation, and lifestyle builds the structure. Teach clients with a family history to elevate their legs, avoid prolonged standing, maintain a healthy weight, and wear compression stockings early to prevent progression. Kicking off with a real-world clinical scenario, imagine a nurse assessing a middle-aged client who complains of discomfort in the lower extremities. The nurse's goal is to determine which statement by the client best indicates the presence of varicose veins. The options presented are option A: my legs ache and feel heavy after I've been standing for several hours. Option B: my feet perspire excessively, especially in warm weather. Option C: I often wake up at night with a restless, tingling feeling in my legs. Option D: I experience sharp pain in my shins when I jog or exercise. The correct answer is option A: my legs ache and feel heavy after I've been standing for several hours. Diving deeper into the reasoning, varicose veins develop when the venous valves become incompetent and the vein walls lose elasticity, resulting in chronic venous hypertension and venous pooling. This leads to the classic dull, aching, and heavy sensation in the legs, especially after long periods of standing or sitting when blood return is reduced. Relief often occurs with leg elevation or walking, which enhances venous return through calf muscle contraction. Over time, this venous congestion can progress to ankle edema, brownish skin pigmentation from hemosiderin deposits, and even venous ulcers, particularly around the medial malleolus. Nurses should carefully inspect for tortuous, bulging veins and evaluate for pitting edema at the end of the day. Adding to that, key risk factors include family history, pregnancy, obesity, aging, and occupations involving prolonged standing or immobility. Preventive strategies revolve around lifestyle modifications such as wearing compression stockings, avoiding extended standing, elevating the legs regularly, maintaining a healthy weight, and performing exercises to strengthen calf muscles, which serve as a natural venous pump. Turning our attention to the incorrect responses, option B, my feet perspire excessively, especially in warm weather, is not linked to venous disease. Excessive sweating or hyperhidrosis involves the autonomic nervous system and sweat glands, not the venous circulation. Option C, I often wake up at night with a restless, tingling feeling in my legs, describes restless leg syndrome, a neurological condition often tied to iron deficiency or dopaminergic dysfunction, unrelated to varicose veins. Option D, I experience sharp pain in my shins when I jog or exercise, suggests intermittent claudication caused by peripheral arterial disease or muscle strain. Remember, arterial pain is exercise-induced and relieved by rest, while venous discomfort intensifies with dependency and improves when the legs are elevated. To tie it all together, here is your Stankos clinical insight. Venous pain worsens with standing and improves with elevation, exactly the opposite of arterial pain. So when a client reports tired, heavy legs with visible bulging veins at the end of the day, think chronic venous insufficiency. Let us kick off this discussion with a practical and relatable situation that every nurse might encounter. Picture a nurse educating a client who has just been diagnosed with varicose veins in both lower extremities. The nurse's goal is to teach effective self-care measures that can relieve symptoms and prevent the condition from worsening. The question asks, which nursing instruction is most beneficial in managing this disorder? The available options are as follows. Option A, elevate your legs frequently during the day. Option B, keep the room temperature above 21 degrees Celsius or 70 degrees Fahrenheit. Option C, massage your calves whenever leg cramps occur. And option D, limit activity and adopt a sedentary lifestyle. The correct answer here is option A, elevate your legs frequently during the day. Moving deeper into the reasoning behind this, elevating the legs above the level of the heart several times a day is the most effective intervention for promoting venous return. Gravity assists in directing blood back toward the heart, thereby reducing venous stasis, swelling, and the heavy, aching sensation associated with varicose veins. In this condition, venous valves lose their competency, and vein walls become distended, leading to pooling of blood and increased venous pressure. By practicing leg elevation for about 15 to 30 minutes, multiple times daily, especially after prolonged standing or sitting, the client helps prevent venous congestion and disease progression. Nurses should also remind clients not to cross their legs, as that further impedes blood flow. Transitioning to option B, keep the room temperature above 21 degrees Celsius or 70 degrees Fahrenheit. It may sound comforting, but has little physiological effect on venous return. In fact, a consistently warm environment might cause excessive vasodilation, which can worsen venous pooling and edema rather than relieve it. Comfort measures are important, but they do not directly address the circulatory problem. Let us now take a closer look at option C, massage your calves whenever leg cramps occur. While this may seem like a soothing practice, it is actually unsafe for clients with varicose veins. Massaging the calves can dislodge an existing thrombus formed due to sluggish blood flow, which can travel to the lungs and cause a pulmonary embolism, a potentially fatal complication. Safer alternatives include gentle stretching, ankle pumping, or walking to activate the calf muscles and promote venous return naturally. Lastly, consider option D, limit activity and adopt a sedentary lifestyle. Although rest might appear beneficial for tired legs, inactivity actually worsens venous stasis. The calf muscles act as a natural venous pump that pushes blood back toward the heart during movement. Without regular use, venous pressure increases, leading to further dilation, swelling, and even skin ulceration. Therefore, clients should be encouraged to engage in regular, moderate activities such as walking or leg exercises to maintain healthy circulation. And as we wrap up this question, here comes your Stancoast Pearl. Elevation, movement, and muscle tone are the triad of venous health. When the legs go up and the muscles move, the veins flow freely. For a quick clinical tip, advise clients to wear graduated compression stockings during the day, maintain an ideal body weight, and avoid tight clothing that restricts circulation. These preventive measures, combined with regular exercise and leg elevation, serve as the foundation of effective conservative management for varicose veins. Let us kick off this question with a practical situation that every nurse faces in daily practice. A nurse is preparing discharge instructions for a client who has just been diagnosed with varicose veins. The client asks which everyday activity should be avoided to prevent the condition from worsening. The question is, which of the following activities should the nurse instruct the client to avoid to reduce venous congestion and promote optimal lower extremity circulation? The available options are option A, walking in supportive athletic shoes, option B, jogging 1 mile daily, option C, sitting with legs crossed at the knees, and option D, wearing wool socks. The correct answer is option C, sitting with legs crossed at the knees. Now, let us explore why this answer makes perfect clinical sense. Clients with varicose veins should avoid any activity that restricts venous return or encourages venous stasis. When the legs are crossed at the knees, the popliteal vein becomes compressed, which obstructs blood flow from the lower extremities back to the heart. This leads to increased venous pressure, distension, and worsening of valve incompetence, resulting in swelling, aching, and heaviness in the legs. Over time, this can progress to chronic venous insufficiency or venous ulceration. Therefore, nurses should emphasize preventive habits such as leg elevation, use of compression stockings, and avoidance of prolonged standing or sitting to support optimal venous return. On the other hand, option A, walking in supportive athletic shoes, is actually one of the best recommendations for clients with varicose veins. Walking activates the calf muscle pump, which pushes venous blood upward toward the heart and prevents blood from pooling in the legs. This simple daily activity improves circulation, enhances muscle tone, and helps maintain healthy venous valve function. Furthermore, option B, jogging 1 mile daily, can also be beneficial if done moderately. Light jogging strengthens the calf muscles, promotes circulation, and prevents venous stasis. However, high-impact or strenuous running may worsen symptoms in clients with advanced varicose veins, so nurses should advise pacing activity according to tolerance. Still, moderate aerobic exercise remains a key part of conservative management, because immobility is far more detrimental than gentle movement. Lastly, option D, wearing wool socks neither improves nor worsens venous circulation. Wool socks simply provide warmth and help absorb moisture. However, clients should avoid socks with tight elastic bands at the top, as these can restrict venous flow. Graduated compression stockings, on the other hand, are beneficial and should be worn during the day to assist venous return and reduce swelling. To wrap this up, here's a stand-coast pearl. Varicose veins hate stagnation. Keep the legs up, moving, and supported. Elevation improves flow, motion activates the calf pump, and compression maintains pressure balance. And before we move on, remember this clinical tip. Advise clients to elevate their legs above heart level for 15 to 30 minutes several times a day. Avoid prolonged sitting or standing. Use prescribed compression stockings, and maintain a healthy body weight. These evidence-based measures are the foundation of effective varicose vein management and prevention. Let's dive straight into a real-world surgical nursing situation that tests both knowledge and logic. A client diagnosed with chronic varicose veins is scheduled for a ligation and vein stripping procedure. After the surgeon provides a detailed preoperative explanation, the client appears worried and asks, "If my veins are being removed, how will the blood in my legs return to the heart after surgery?" The nurse must now provide the most accurate and reassuring response about how venous circulation works after surgery. The available options are: option A, some of the arteries begin to function as veins. Option B, new veins will grow to replace the ones that were removed. Option C, other veins will take over the work of those that are removed. And option D, the healthy vein ends are surgically attached to other veins. The correct answer is option C, other veins will take over the work of those that are removed. During vein ligation and stripping, the surgeon removes the damaged superficial veins, usually the great or small saphenous veins, that have lost their valve function, causing blood pooling and pressure in the lower legs. However, the deep venous system, which handles about 90% of blood return to the heart, remains intact and fully functional. After surgery, blood is naturally rerouted through these deeper, healthy veins that have competent valves, allowing for improved venous return and reduced swelling, pain, and heaviness. This procedure, therefore, enhances circulation rather than impairs it. Now, looking at option A, the suggestion that arteries can function as veins is incorrect, because arteries and veins serve opposite purposes and have completely different structures. Arteries carry oxygenated blood under high pressure away from the heart, while veins carry deoxygenated blood under low pressure back to the heart, using valves to prevent backflow. They cannot replace one another due to these anatomical and physiological differences. As for option B, it is also incorrect to say new veins will grow. The human body does not regenerate large new veins. While some collateral vessels may enlarge slightly over time, this is not the same as new vein formation. The improvement seen after surgery occurs because the faulty veins are removed, forcing blood to reroute efficiently through the existing, healthy venous pathways. Moving to option D, this statement is inaccurate because during a vein stripping procedure, the ends of the removed veins are ligated, or tied off, rather than being reattached to other veins. This prevents bleeding and ensures the incompetent veins no longer cause venous stasis or reflux. To close this concept, here's the stand-coast pearl. After varicose vein surgery, blood flow is not lost, it is optimized. The deep veins continue to carry blood efficiently once the damaged superficial veins are removed. Think of it like diverting traffic from a blocked, congested road onto a smooth, open highway. Circulation becomes faster, clearer, and far more effective. Moving into our next high-yield scenario, a nurse is planning the post-operative care of a client who has just undergone a ligation and vein stripping procedure for varicose veins. The question asks which nursing intervention should be identified as the highest priority during the immediate post-operative period. The available options are as follows. Option A suggests providing a protein-rich diet to promote tissue healing. Option B recommends ambulating the client early and frequently as ordered. Option C focuses on monitoring for signs of wound infection and redness. Option D emphasizes assessing for the presence of frequent leg cramping. The correct answer is option B, ambulate the client early and frequently as ordered. Early ambulation is the key element of post-operative management after vein stripping and ligation procedures. The main goal in this stage is to maintain effective venous circulation, prevent venous stasis, and reduce the risk of developing a deep vein thrombosis. Because the surgery involves the removal of superficial incompetent veins, temporary impairment of venous return can occur until collateral circulation develops through the deep venous system. To counter this, nurses assist clients to ambulate for short intervals, usually every hour while awake, beginning as soon as it is medically safe. This movement activates the calf muscle pump, enhances venous blood flow, minimizes edema, and prevents clot formation. Compression stockings or elastic bandages are often applied postoperatively to further support venous return. Therefore, early ambulation directly addresses the top postoperative priority, restoring circulation and preventing thromboembolic complications. Turning to option A, providing a protein-rich diet supports tissue repair and wound healing, but it does not take precedence in the immediate postoperative period. Although protein is vital for recovery and collagen formation, nutritional interventions do not prevent life-threatening complications such as venous stasis or deep vein thrombosis. Looking next at option C, monitoring for signs of wound infection and redness is certainly important. However, infection risk typically arises a few days after surgery, once bacterial colonization can occur. In the early hours after the procedure, circulation and clot prevention are the primary concerns, not infection surveillance. Finally, option D, assessing for frequent leg cramping, is of lesser importance. Mild soreness or tightness can occur, but persistent cramping rarely indicates a serious postoperative problem. Focusing on this would divert attention from the more critical intervention, promoting mobility and maintaining venous return. In summary, early ambulation remains the highest priority for promoting circulation, preventing deep vein thrombosis, and ensuring a smooth recovery following vein stripping surgery. To wrap this scenario up and connect it to practical nursing insight, let us look at the Stan Coast Clinical Pearl. After vein stripping, movement means life. Early ambulation prevents clot formation, boosts venous return, and reduces postoperative swelling. Remember, circulation first, nutrition next. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Moving forward to reinforce this concept for your NCLEX success, here is the high-yield NCLEX concept. Always prioritize nursing actions that prevent immediate life-threatening complications such as deep vein thrombosis, pulmonary embolism, or circulatory compromise. For clients undergoing vein surgery, ambulation and leg exercises come first, while nutrition and infection control follow once the client is stable. Let us dive straight into an ethical and safety-based nursing situation that challenges clinical judgment. A post-operative client reports moderate surgical pain and requests medication for relief. The physician has prescribed ibuprofen 200 milligrams by mouth every 4 to 6 hours as needed. However, when the nurse offers the medication, the client immediately says, "If that is Motrin, I do not want it. It always makes me sick to my stomach." The question now is, which nursing action would be the most appropriate in this situation? The options are: Option A, tell the client that the medication is ibuprofen. Option B, explain that the medication must be taken as prescribed. Option C, encourage the client to take the medication with plenty of water. And option D, withhold the medication and report the client's statement to the charge nurse or provider. The correct answer is option D, withhold the medication and report the client's statement to the charge nurse or provider. Exploring the reasoning behind this decision, when a client refuses a medication because of a previously experienced adverse effect, the nurse's role is to protect the client's safety and advocate for alternative management. Ibuprofen, known commercially as Motrin, is a non-steroidal anti-inflammatory drug commonly used to relieve mild to moderate postoperative pain, but it is also known for causing gastric irritation, nausea, and even ulcers, particularly if taken without food. The client's statement that "it makes me sick to my stomach" signals intolerance or an adverse reaction. Therefore, the appropriate nursing response is to withhold the medication, document the statement, and promptly notify the charge nurse or healthcare provider. This action allows for a reassessment of pain management and for safer alternatives such as acetaminophen to be prescribed. By doing this, the nurse upholds the ethical principle of non-maleficence, meaning do no harm, and respects client autonomy, ensuring that the client's right to refuse care is honored. Turning to the incorrect options, option A, telling the client that the medication is ibuprofen, is unsafe and unethical. Although ibuprofen and Motrin refer to the same drug, using the generic name to bypass the client's concern would constitute deception and a violation of informed consent. Clients must always know what medication they are receiving, and their previous experiences must guide safe practice. Next, option B, explaining that the medication must be taken as prescribed, is also inappropriate. Nurses cannot coerce clients into taking medication, especially if it has caused discomfort or harm before. Forcing administration disregards patient autonomy and fails to recognize potential danger. The correct approach is to respect the refusal and report it to the provider for review. Moving forward, option C, encouraging the client to take the medication with plenty of water, may sound like good advice for preventing mild stomach upset, but it is not suitable here. This client has already reported intolerance to the drug, meaning even with water or food, gastric irritation and nausea could still occur. Administering the drug anyway could lead to worsened gastrointestinal injury or even bleeding, making this option unsafe. In contrast, option D, withholding the medication and reporting to the charge nurse or provider, is the correct course of action. This step prioritizes the client's well-being, prevents further harm, and fosters communication among the care team to ensure a safer, individualized treatment plan. To reinforce this learning, remember the Stan Coast clinical pearl. Never override a client's experience with a medication. Every reported intolerance is a safety signal. When in doubt, stop, verify, and notify. And for the NCLEX high-yield concept, always respect a client's right to refuse medication and report refusals appropriately. Recognize that brand and generic names describe the same drug. Substituting one for the other without addressing adverse reactions is unethical and unsafe. Ultimately, nursing is about advocacy, safety, and trust. Protecting the client must always come before routine administration. Moving into this next scenario, picture a 67-year-old client who has been battling chronic venous insufficiency for many years and now presents with a non-healing ulcer on the medial aspect of the lower leg. The nurse performs a focused assessment of the affected site and must identify which findings are typical of venous stasis ulcers. The available options are option A, purulent drainage from lesions, option B, blanched patches around open areas, option C, dark brown, dry and crusty skin, option D, fluid-filled blisters, option E, edema in the lower legs, and option F, a fine red rash below the knee. The correct answers are option C and option E, dark brown, dry and crusty skin, and edema in the lower legs. To explain further, venous stasis ulcers are classic complications of chronic venous insufficiency, a condition caused by incompetent venous valves that allow blood to pool in the lower extremities. This constant venous congestion raises hydrostatic pressure, leading to the leakage of red blood cells and plasma into surrounding tissues. The breakdown of hemoglobin releases hemosiderin, which produces the characteristic brownish or bronze discoloration around the ankles and lower legs. Over time, the skin becomes dry, thick, scaly, and crusted due to poor tissue oxygenation and chronic inflammation. Edema, as described in option E, results from the continuous escape of fluid into the interstitial spaces. The swelling compromises circulation and nutrient delivery to the skin, worsening ulcer formation, typically found on the medial malleolus, or lower leg. These ulcers are usually shallow, irregular in shape, and exude serous or serosanguineous fluid rather than pus. Let us analyze why the other options are incorrect. Option A, purulent drainage from lesions, indicates infection rather than a typical venous ulcer feature. Option B, blanched patches around open areas, aligns more with arterial ulcers caused by ischemia and reduced blood flow, not with venous congestion. Option D, fluid-filled blisters, are signs of acute conditions such as burns or dermatitis, not chronic venous insufficiency. Option F, a fine red rash below the knee, represents dermatitis or allergic irritation rather than stasis-related skin changes. The Stancoast Clinical Pearl reminds us, think brown and swollen for venous ulcers, brown pigmentation from hemosiderin, swollen legs from edema. In contrast, think pale and painful for arterial ulcers. Finally, the NCLEX high-yield concept emphasizes that venous stasis ulcers stem from impaired venous return, not arterial blockage. To differentiate during exams, remember these quick contrasts. Venous ulcers commonly appear on the medial ankle or lower leg, cause dull aching pain, show brown and scaly skin, and are accompanied by edema that improves with elevation. On the other hand, arterial ulcers are found on the toes, or lateral malleolus, cause sharp pain, have pale, cool, shiny skin, and worsen with leg elevation. Let us explore this insightful scenario that focuses on enhancing venous circulation in a post-operative client with chronic venous insufficiency. The nurse is designing a comprehensive care plan for a client who reports mild aching in the lower extremities, and the goal is to promote venous return while preventing further complications from venous stasis. The question asks which nursing intervention would be most effective in promoting venous circulation. The options are: Option A, offer the client a mild analgesic for leg discomfort. Option B, apply graduated elastic compression stockings to the legs. Option C, encourage an oral fluid intake of at least 2,500 milliliters daily. And Option D, apply a heating pad to the affected extremities. The correct answer is Option B. Apply graduated elastic compression stockings to the legs. Now let us unfold the clinical reasoning behind this choice. Chronic venous insufficiency occurs when venous valves fail to function properly, leading to increased venous pressure, blood pooling, and tissue congestion. This chronic state promotes edema, hypoxia, and eventually ulceration due to impaired oxygen delivery to tissues. The main nursing objective is to promote venous return and minimize venous congestion. Graduated compression stockings are highly effective because they provide the strongest pressure at the ankle, about 35 to 40 millimeters of mercury, and gradually reduce pressure upward along the leg. This gradient mimics the body's natural venous system, helping to push blood back toward the heart, decrease edema, counteract hydrostatic pressure, and prevent ulcer formation. These stockings should be applied in the morning before the client gets out of bed, worn during the day, and removed only at bedtime to optimize circulation. Regular skin assessments are essential to prevent pressure injuries or restricted blood flow. Looking closely at the other options, we see why they are less appropriate. Option A, offering a mild analgesic, is incorrect because while it helps relieve discomfort, it does not address the underlying circulatory issue or improve venous return. Option C, encouraging oral fluid intake of at least 2,500 milliliters daily, is not suitable because excessive fluid may worsen edema in clients with venous insufficiency, particularly those who also have heart failure. Option D, applying a heating pad to the affected extremities, is unsafe because heat causes vasodilation, which increases venous congestion, capillary permeability, and fluid leakage, aggravating swelling and discomfort. Here's the key takeaway from this scenario. Compression is the cornerstone of venous therapy. It supports venous return, minimizes stasis, and accelerates healing of venous ulcers. Always remember, this simple Stancoast clinical pearl: up for arteries, down for veins. Elevate the legs and use compression to aid circulation and relieve symptoms. And for your NCLEX memory, think of this high-yield trick. Venous problems are brown, swollen, and better with elevation, while arterial problems are pale, painful, and worse with elevation. Let us now turn our attention to an important NCLEX-style clinical scenario that focuses on wound healing assessment in a client with chronic venous insufficiency. The question presents a nurse evaluating the progress of wound healing in a client who has a long-standing venous stasis ulcer on the lower leg. After several weeks of consistent compression therapy and appropriate wound care, the nurse must determine which finding provides the best evidence that the ulcer is healing. The available options are as follows. Option A, the wound becomes smaller and drainage increases. Option B, the wound becomes smaller and the client reports less discomfort. Option C, the wound becomes smaller and the wound bed appears pink. And option D, the wound becomes smaller and the wound margins appear white. The correct answer is option C, the wound becomes smaller and the wound bed appears pink. To understand why, let us explore the clinical reasoning behind this. Venous stasis ulcers develop as a result of chronic venous hypertension caused by incompetent valves, venous congestion, and impaired tissue oxygenation. This leads to edema, accumulation of metabolic waste, and eventually ulceration, most commonly around the medial malleolus. Healing in such ulcers depends on restoring venous return, controlling infection, and promoting granulation tissue formation. The most reliable and visible indicator of healing is the appearance of healthy pink or red granulation tissue in the wound bed. This new tissue contains capillaries, fibroblasts, and collagen fibers, all of which nourish the area and facilitate epithelial regeneration. The pink hue reflects adequate blood flow and oxygenation, key elements that confirm active tissue repair. Over time, as the wound heals, granulation tissue contracts and epithelial cells migrate inward, leading to gradual closure of the wound. However, not all changes suggest healing progress. Looking at the other options helps clarify this further. Option A, which mentions increased drainage despite a smaller wound, is incorrect, because a rise in drainage, especially if it becomes thick, cloudy, or foul-smelling, often indicates ongoing inflammation or infection. Option B, decreased discomfort, is not a definitive marker either, as venous ulcers are typically not very painful even in their active phase. Thus, reduced pain may occur independently of healing. Option D, white wound margins, should be seen as a warning sign. White or pale edges often indicate maceration, ischemia, or cell death rather than epithelial regeneration. Healthy wound margins should appear pink, moist, and slightly shiny, reflecting epithelial cell migration. To tie it all together, remember this essential Stand Coast clinical insight. Pink means progress. White means worry. The presence of pink granulation tissue confirms adequate perfusion and a healthy healing process, while white, black, or sloughy tissue calls for reassessment of oxygenation, infection control, and moisture balance. Here is a NCLEX memory trick to seal this concept in your mind. Pink is progress. Pus is problem. When you see a wound turning pink, it signals active healing and tissue recovery. But when you notice pus or odor, it means infection is interfering with the healing cascade. This visual and conceptual cue helps nurses quickly interpret wound appearance during clinical evaluations and make appropriate care decisions. Moving forward to an essential NCLEX concept, a nurse applies an air-occlusive dressing over a client's venous leg ulcer after cleansing and debridement. When the client curiously asks, "What is the main advantage of using this type of dressing instead of regular gauze?" the nurse must identify the correct response that best explains its therapeutic benefit. The possible answers include Option A, it will reduce the formation of scar tissue. Option B, it will relieve pain from skin irritation. Option C, it will be less expensive than gauze dressings. And Option D, it will speed healing by keeping the wound moist. The correct answer is Option D. It will speed healing by keeping the wound moist. To understand this clearly, let us explore the clinical science behind moist wound healing. Air-occlusive dressings, also known as semi-occlusive or hydrocolloid dressings, create a sealed, moisture-retentive environment over the wound bed. This moisture prevents the evaporation of wound exudate, which contains growth factors, cytokines, and enzymes that actively support tissue regeneration. By maintaining an ideal temperature and hydration level, these dressings enhance cell migration, angiogenesis, and collagen synthesis, 3 vital steps in forming granulation tissue and promoting epithelialization. In comparison, traditional gauze dressings allow the wound to dry out and form a hard scab that delays epithelial migration and traps viable cells beneath the surface, ultimately slowing the healing process. Maintaining a moist but non-macerated wound bed allows the tissue to heal more efficiently through secondary intention. The moist environment also cushions exposed nerve endings, resulting in reduced pain while stimulating capillary budding that improves tissue oxygenation internally. Although reduced scar formation may occur secondarily due to smoother collagen organization, that is not the main therapeutic purpose. Another advantage is that these dressings can remain in place for up to 7 days, minimizing dressing changes, protecting fragile new tissue, and reducing infection risk. Even though air-occlusive dressings are initially more expensive than gauze, their long-term cost-effectiveness lies in faster healing, fewer dressing changes, and greater client comfort. Looking at the incorrect options, option A, it will reduce the formation of scar tissue, is not the primary reason for use. While the moist environment can result in smoother cosmetic healing, its direct function is to promote epithelialization, not to prevent scarring. Option B, it will relieve pain from skin irritation. May occur as a secondary benefit since moist dressings protect nerve endings, but pain relief is not their main goal. Option C, it will be less expensive than gauze dressings. Is inaccurate because the initial cost of air-occlusive dressings is higher, although overall savings occur due to faster recovery and fewer changes. And finally, here comes your Stan Coast clinical pearl. Remember, dry wounds delay, moist wounds mend. A moist wound supports cellular migration, activates growth factors, and promotes angiogenesis, the triad responsible for faster, healthier healing. For a quick NCLEX memory trick, think moist means move. Cells move, capillaries grow, and wounds close. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Let us now explore a high-level NCLEX question that assesses your understanding of circulatory compromise and tissue viability. A nurse is assessing several clients during morning rounds. The question asks, which of the following clients are at the highest risk for developing gangrene of the foot? You can choose more than one option, as this is a select all that apply question. The options include option A, an insulin-dependent diabetic client, option B, an elderly man with impaired circulation, option C, a woman who sustained trauma to the toes, option D, a homeless person with osteoarthritis, option E, a client who is taking Warfarin, also known as Coumadin, and option F, a client with a history of myocardial infarction. The correct answers here are options A, B, and C. The insulin-dependent diabetic client, the elderly man with impaired circulation, and the woman who sustained trauma to the toes. To understand this thoroughly, let us unfold the clinical reasoning behind these correct choices. Gangrene represents the death of tissue caused by severe arterial insufficiency, where oxygen and nutrients fail to reach the cells. This leads to ischemia, necrosis, and, if untreated, decomposition of the affected area. It most commonly affects the toes or feet and is a medical emergency that can progress to sepsis or amputation if not promptly managed. Looking first at option A, the insulin-dependent diabetic client. This is correct because diabetes is one of the strongest risk factors for gangrene. Chronically elevated blood glucose damages small blood vessels and nerves, reducing circulation and sensation. When a minor wound or blister occurs, the lack of pain perception and delayed healing allow infection and tissue death to develop silently. These clients often present with diabetic foot ulcers, which are responsible for the majority of non-traumatic amputations worldwide. Now shifting to option B, the elderly man with impaired circulation. This is also correct. Age-related changes, such as arterial stiffening and atherosclerosis, reduce peripheral perfusion, especially in the lower limbs. Even a small cut or pressure injury on the foot can progress into a gangrenous ulcer if blood flow is not restored. Nurses must prioritize preventive foot care, including regular inspection, protective footwear, and maintaining adequate hydration and mobility to promote circulation. Turning next to option C, the woman who sustained trauma to the toes, this too is correct. Any direct injury can disrupt local blood supply, triggering inflammation and tissue hypoxia. If the affected area cannot re-establish circulation, necrosis follows. Trauma-related gangrene is particularly dangerous in individuals with coexisting diabetes or peripheral vascular disease, as the healing potential is already compromised. In contrast, option D, the homeless person with osteoarthritis, is incorrect. Osteoarthritis is a degenerative joint condition and does not cause arterial insufficiency, while homelessness may predispose an individual to environmental injuries or infections. The osteoarthritis itself does not directly increase gangrene risk. Moving to option E, the client taking Warfarin, this is also incorrect. Warfarin is an anticoagulant that prevents clot formation and therefore typically improves circulation rather than restricting it. Although rare cases of Warfarin-induced skin necrosis exist, they are uncommon and usually occur in those with a specific clotting protein deficiency. Finally, option F, the client with a history of myocardial infarction, is not correct because a heart attack involves coronary arteries, not peripheral ones. Unless this client also has peripheral artery disease, their risk for foot gangrene is minimal. The focus for such clients remains on cardiac rehabilitation and secondary prevention of coronary events. Here is a vital Stancoast clinical pearl to remember. Gangrene grows where oxygen cannot go. Always assess peripheral pulses, capillary refill, temperature, and skin color in clients with vascular issues. The classic triad of pain, pallor, and pulselessness warns of impending necrosis. Early recognition and interventions, such as glucose regulation, smoking cessation, and antiplatelet therapy, can prevent irreversible tissue death. Lastly, the Stancoast high-yield NCLEX. Tip to imprint in your memory is this. The three primary causes of gangrene are diabetes mellitus, peripheral artery disease, and local trauma. Whenever these appear in an NCLEX question, prioritize vascular assessment, wound protection, and infection prevention as your key nursing interventions. Moving ahead to an insightful clinical scenario, let us analyze a question that focuses on surgical risk assessment. A nurse is obtaining the admission history of a 57-year-old client who is scheduled for abdominal surgery. The question asks, which of the following findings should the nurse recognize as significant risk factors for developing post-operative thrombophlebitis and report to the physician? The options include option A, the client weighs 350 pounds or 159 kilograms. Option B, the client smokes 2 packs of cigarettes per day. Option C, the client has been on prolonged bed rest due to heart failure. Option D, the client complains of leg fatigue after standing. Option E, the client reports cramping in the lower leg at night. And option F, the client reports generalized joint pain. The correct answers are options A, B, and C. Now, let us explore the reasoning behind these correct answers in depth. Thrombophlebitis refers to an inflammatory condition of a vein accompanied by thrombus, or clot, formation that partially or completely blocks venous blood flow. It is most frequently seen in the deep veins of the lower extremities and is a major post-operative concern due to the combined effects of venous stasis, endothelial injury, and hypercoagulability, collectively known as Versau's triad. Factors such as surgical stress, anesthesia, and immobility heighten these risks, making early recognition and prevention absolutely crucial. Focusing first on option A, the client weighing 350 pounds or 159 kilograms, this is correct because obesity contributes heavily to venous stasis. The excess adipose tissue compresses pelvic and leg veins, restricting blood return to the heart. Obesity also causes limited mobility, elevated intra-abdominal pressure, and altered coagulation patterns, all of which promote deep vein thrombosis. Moreover, chronic inflammation and endothelial dysfunction associated with obesity further accelerate clot formation. Transitioning to option B, smoking 2 packs of cigarettes daily is another significant and correct risk factor. Cigarette smoking increases platelet adhesiveness, causes vasoconstriction through nicotine, and reduces oxygen carrying capacity due to carbon monoxide exposure. These physiological changes lead to endothelial damage and activation of clotting pathways. Smoking also delays postoperative wound healing, heightens hypoxia, and increases the risk of cardiovascular and thrombotic complications, making preoperative cessation advice essential. Moving on to option C, prolonged bed rest resulting from heart failure is also correct. Immobility decreases calf muscle activity, which is responsible for pushing venous blood back toward the heart. In addition, heart failure leads to reduced cardiac output and venous congestion, worsening stasis. The longer the period of immobility, the greater the likelihood of clot formation in the deep veins. However, option D, the complaint of leg fatigue after standing, is incorrect because it is more closely associated with varicose veins or chronic venous insufficiency rather than acute thrombophlebitis. This type of fatigue results from valve incompetence and not clot obstruction. Likewise, option E, cramping in the lower leg at night, is not linked to thrombophlebitis, but instead points to electrolyte imbalances such as hypokalemia or magnesium deficiency. Finally, option F, generalized joint pain, typically reflects musculoskeletal or autoimmune inflammation like arthritis, not vascular disease. To conclude this discussion with a high-yield review, remember the Stan-Coast clinical pearl. Virchow's triad equals stasis, vessel injury, and hypercoagulability. Every NCLEX question on thrombosis can be decoded by identifying which of these three components are present. The greater the overlap, the higher the client's risk of developing deep vein thrombosis or pulmonary embolism. For an extra Stan-Coast high-yield NCLEX tip, always assess preoperative clients for modifiable thrombotic risks, such as smoking, obesity, immobility, and dehydration. Nursing priorities include promoting early ambulation, applying sequential compression devices, administering prophylactic anticoagulants as prescribed, and monitoring for warning signs like unilateral swelling, warmth, and tenderness. By staying alert to these subtle yet critical indicators, nurses can prevent life-threatening post-operative complications and ensure safer surgical recovery outcomes. Before we move on to the next NCLEX topic, let me share something that could be the game changer in your journey. If you are determined to pass the NCLEX on your very next attempt, the Ultimate NCLEX Crash Course is exactly what you need. This program has already helped more than 100,000 nursing students achieve success. And now, it's your turn. Here is what makes it powerful. Daily interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks and PDF notes for quick revision, a ready-to-use student planner, and detailed NGN question breakdowns in comprehensive lectures. It is not just a course, it's your all-in-one NCLEX toolkit. Simply scan the QR code now or click the link in the description to enroll instantly. You'll unlock free content like PDF notes, practice tests, and NCLEX quizzes, plus access to our Telegram and WhatsApp groups filled with even more free resources to keep you ahead. Transitioning to an important clinical reasoning scenario, imagine a post-operative client who is 2 days after abdominal surgery and has been ambulating only when encouraged, often refusing to get out of bed due to pain. The question asks which nursing observation would most likely predispose this client to developing a deep vein thrombosis, or DVT, in the lower extremities. Here are the options. Option A, the client resists ambulation. Option B, the client breathes shallowly. Option C, the client requests analgesics frequently. Option D, the client drinks coffee excessively. The correct answer is Option A, the client resists ambulation. Let us now understand why this is the correct choice. Deep vein thrombosis is a common postoperative complication that arises due to Virchow's triad: venous stasis, endothelial injury, and hypercoagulability. Among these three, venous stasis plays the most critical role in immobile clients. When a postoperative client refuses to ambulate, the absence of skeletal muscle contractions in the lower extremities leads to sluggish venous return from the legs to the heart. This stagnation allows blood to pool within the deep veins, creating a perfect condition for platelet aggregation and thrombus formation. Abdominal surgery adds to the risk by increasing intra-abdominal pressure and causing vascular inflammation, further impairing venous flow. Therefore, early and frequent ambulation becomes one of the most effective nursing interventions to prevent post-operative DVT. Now, looking deeper into the option analysis, Option A, the client resists ambulation, is correct because immobility directly results in venous stasis, one of the most preventable contributors to thrombosis. When the calf muscles are inactive, the muscle pump mechanism that assists in venous return is lost, allowing clots to form easily. Option B, the client breathes shallowly is incorrect because while shallow breathing may predispose to respiratory complications like pneumonia or atelectasis, it has no direct influence on venous circulation. Option C, the client requests analgesics frequently is also incorrect. Pain management is essential after surgery. In fact, adequate pain control promotes early ambulation and reduces the risk of DVT. Lastly, option D, the client drinks coffee excessively is incorrect because caffeine, though mildly vasoconstrictive, does not cause venous stasis or promote thrombosis formation. To conclude, the nursing focus should be on promoting early mobility and implementing adjunct measures such as leg exercises, sequential compression devices, anti-embolism stockings, maintaining hydration, and administering anticoagulant prophylaxis like heparin or enoxaparin as prescribed. To wrap up this clinical discussion with key takeaways, let us highlight the Stan Coast clinical pearl. Immobility after surgery silently triggers venous thrombosis. Remember, movement is medicine. Even a few steps stimulate the calf muscle pump and prevent stasis. Moving forward to reinforce your NCLEX preparation, here is the Stan Coast high-yield NCLEX tip. Always assess post-operative clients for the 3 key signs of DVT: unilateral swelling, warmth, and tenderness, and reinforce early ambulation. The golden rule to remember is move to improve circulation. Moving forward into another critical nursing assessment scenario, imagine a post-operative client who has been prescribed anti-embolism stockings as part of a venous thromboembolism prevention plan. The nurse is evaluating the client after applying the stockings and must determine which observation provides the best evidence that the stockings are the correct size and fit. The available options are as follows. Option A, the stockings extend to mid-calf level. Option B, the client's toes feel warm and pink when touched. Option C, the stockings were easy to put on without resistance. Option D, the heels show no areas of redness or pressure. The correct answer is option B, the client's toes feel warm and pink when touched. Now let us explore the expanded rationale in detail. Properly fitted anti-embolism stockings, also known as graduated compression stockings, are essential for preventing venous stasis and deep vein thrombosis in post-operative clients. The most accurate indicator that the stockings are correctly sized and allowing proper circulation is when the toes remain warm, pink, and demonstrate a capillary refill time of less than 3 seconds. This finding confirms that arterial blood flow to the extremities remains intact while venous return is being effectively promoted. Before applying these stockings, the nurse should always measure the client's calf circumference and leg length, either from the heel to the popliteal space for knee-length stockings or to the gluteal fold for thigh-length ones, to ensure an accurate fit. A properly fitted pair delivers graduated compression that is strongest at the ankle, about 18 millimeters of mercury, and gradually decreases toward the knee or thigh, thereby promoting upward venous flow toward the heart. If the stockings are too tight, they can restrict arterial blood flow, causing cold, cyanotic toes and even tissue ischemia. On the other hand, if they are too loose, the intended compression benefit is lost, making them ineffective in preventing venous thromboembolism. It is also vital for the nurse to perform frequent assessments after application. The stockings should be removed at least once every shift to inspect the skin for any signs of irritation, redness, or pressure injury. Clients should also be taught to avoid folding or rolling down the stockings because this creates a tourniquet effect that may obstruct circulation. Let us now review why the other options do not represent the correct response. Option A, which mentions that the stockings extend to mid-calf, is inaccurate because length alone does not verify proper fit or effective circulation. Stockings that are too short may fail to cover enough of the leg, leaving certain regions vulnerable to venous pooling. Option C, which states that the stockings were easy to put on without resistance, actually indicates an improper fit, as correctly sized stockings should feel snug and require controlled, even effort to apply smoothly without wrinkles. Option D, which notes that the heels show no redness or pressure, reflects good skin care, but does not confirm that circulation or compression levels are appropriate. Transitioning to a deeper learning moment, here's the Stan Coast clinical pearl. Warm toes and brisk capillary refill are the nurse's best confirmation that compression stockings are doing their job, supporting veins, not suffocating them. And finally, leading into the key testing strategy, here is the Stan Coast high-yield NCLEX tip. Always check circulation, sensation, and movement, commonly referred to as CSM, after applying compression stockings. Remember this simple formula for safety. Snug fit with warm toes equals the correct size, while tight fit with pale, cold toes signals a danger sign that requires immediate reassessment. Moving ahead into a clinically significant nursing assessment scenario, consider a post-operative client being evaluated for a possible deep vein thrombosis. The nurse decides to assess for the presence of Hohmann's sign, and the question asks which technique correctly reflects this assessment. The options presented are as follows. Option A suggests having the client push each foot firmly against the mattress. Option B advises extending each leg and gently dorsiflexing the foot toward the head. Option C proposes asking the client to sit upright and point all toes forward. And Option D recommends asking the client to tighten and contract the thigh muscles. The correct answer is Option B, extend each leg and gently dorsiflex the foot toward the head. Diving deeper into the reasoning, Hohmann's sign is an older clinical maneuver historically used to detect deep vein thrombosis by checking for pain in the calf during passive dorsiflexion of the foot. The correct technique involves fully extending the client's knee and then dorsiflexing the ankle so the toes move toward the head. If the client experiences sharp pain or tenderness in the calf, this may indicate inflammation or thrombosis in the deep veins. However, it is important to note that this test has become outdated and unreliable due to its low diagnostic accuracy and the potential risk of dislodging a thrombus, which could cause a life-threatening pulmonary embolism. In current evidence-based nursing practice, Hohmann's sign has been replaced by more accurate and safer assessment methods. Nurses now rely on Doppler ultrasound studies, measurement of calf circumference, and clinical observations such as unilateral leg swelling, warmth, redness, tenderness, and increased calf diameter, compared to the unaffected leg. Importantly, nurses should avoid manipulating or massaging the suspected limb, as this can increase the risk of embolization. Instead, preventive nursing care focuses on interventions such as encouraging early ambulation, using anti-embolism stockings, and applying sequential compression devices to promote venous return and prevent clot formation. As for the incorrect options, Option A, having the client push the feet against the mattress, merely tests muscular strength and does not assess for venous obstruction. Option C, asking the client to point the toes forward, involves plantar flexion, which does not stretch the calf muscles or assess for venous tenderness. Option D, asking the client to contract the thigh muscles, evaluates muscle tone rather than venous inflammation, making it clinically irrelevant for DVT assessment. Transitioning into a key insight for learners, Stan Coast Clinical Pearl. A positive Hohmann's sign may hint at deep vein thrombosis, but modern. Nursing relies on objective assessment, such as asymmetrical swelling, localized warmth, and Doppler confirmation, rather than provoking pain through outdated methods. And as an additional takeaway, Stan Coast High-Yield NCLEX. Tip: Hohmann's sign equals dorsiflexion pain in the calf, but evidence-based nursing emphasizes prevention and non-invasive diagnostics. If DVT is suspected, avoid massaging or manipulating the affected leg and promptly notify the healthcare provider. Transitioning into a critical post-operative nursing scenario, imagine a client who has been confined to bed rest for an extended period and suddenly reports tenderness and mild swelling in the left calf. The nurse, suspecting the onset of a deep vein thrombosis, or DVT, proceeds to assess for the presence of Hohmann's sign. The question to consider here is, which client response would the nurse expect if a thrombus has formed in the leg vein? The options presented are as follows. Option A states, sharp, immediate calf pain during dorsiflexion of the foot. Option B suggests, sudden numbness in the affected foot. Option C indicates, inability to flex or extend the knee joint. And Option D notes, tingling sensation throughout the affected leg. The correct answer is Option A, sharp, immediate calf pain during dorsiflexion of the foot. Exploring the clinical reasoning behind this, when a thrombus develops within a deep vein of the leg, it obstructs venous return and triggers inflammation of the vessel wall, known as Thrombophlebitis. The traditional, though now outdated, assessment method called Hohmann's sign is performed by dorsiflexing the client's foot while the knee remains extended. A positive response is marked by sharp or cramping pain in the calf, suggesting irritation of the inflamed venous endothelium as the muscles are stretched. Although this maneuver historically indicated possible DVT, it is now discouraged due to its low reliability and potential danger. Manipulating the limb may dislodge the thrombus, leading to a life-threatening pulmonary embolism. In today's evidence-based nursing practice, objective diagnostic methods such as Doppler ultrasonography, venous duplex scanning, and D-dimer testing have replaced Hohmann's sign. Clinically, DVT often manifests as unilateral calf swelling, redness, warmth, tenderness, and a sense of heaviness or tightness in the affected leg. The nurse should never massage or apply pressure to the suspected area. Instead, the correct intervention is to place the client on bed rest, elevate the limb slightly, and immediately notify the healthcare provider for further evaluation and treatment. Preventive strategies include early ambulation, use of compression stockings or sequential compression devices, adequate hydration, and prophylactic anticoagulant therapy for clients at high risk. Moving to the explanation of incorrect options, Option B, sudden numbness in the affected foot, suggests a neurological issue such as peripheral nerve compression or arterial occlusion, not a venous clot. DVT typically causes pain and swelling, not sensory loss. Option C, inability to flex or extend the knee joint, indicates a musculoskeletal or joint-related problem like arthritis or contracture, rather than venous inflammation. DVT restricts comfort due to tenderness, not mechanical joint movement. Lastly, Option D, tingling sensation throughout the affected leg, points toward nerve irritation or diabetic neuropathy. The pain of DVT is localized to the calf, not diffuse or tingling in nature. As an important takeaway before we proceed further, Stan Coast Clinical Pearl, Hohmann's sign may raise suspicion of DVT, but today's nursing standards rely on objective indicators, unilateral swelling, warmth, redness, and confirmed Doppler results, rather than outdated pain-based methods. Finally, adding an extra layer of exam insight, Stan Coast High-Yield NCLEX. Tip: whenever DVT is suspected, refrain from massaging or manipulating the affected limb. Prioritize bed rest, gentle limb elevation, and prompt provider notification for diagnostic confirmation and initiation of anticoagulant therapy. Moving into a critical post-operative situation, imagine a client who has been confined to bed rest for an extended duration and suddenly reports tenderness and mild swelling in the left leg. The nurse immediately suspects the development of a deep vein thrombosis, commonly referred to as DVT, a condition where a thrombus or blood clot forms within a deep vein, most often in the lower extremities. The clinical question here asks, aside from a positive Hohmann sign, which additional assessment finding most strongly supports the nurse's assumption that a thrombus has formed in the leg vein? The options presented are as follows. Option A, the foot on the affected leg appears cyanotic or blue. Option B, the affected leg is warmer than the other. Option C, the capillary refill time is approximately 2 seconds. And Option D, the lower affected leg is swollen. The correct answer is Option D, the lower affected leg is swollen. Delving into the pathophysiology behind this, when a thrombus forms within a deep vein, it obstructs venous return from the distal portion of the leg, leading to venous congestion, increased hydrostatic pressure, and leakage of fluid into the interstitial tissues. This sequence of events results in unilateral swelling or edema of the affected extremity, often accompanied by tenderness, warmth, and a sense of heaviness. The skin over the area may appear taut, shiny, and slightly erythematous. This swelling is considered one of the most consistent and reliable clinical indicators of DVT and often presents before any other sign. The mechanism involves Virchow's triad, venous stasis, endothelial injury, and hypercoagulability, all of which contribute to thrombus formation and propagation. Looking closely at the individual options, Option A, stating that the foot appears cyanotic or blue, is incorrect because cyanosis is more typical of arterial insufficiency, where oxygenated blood flow is reduced. In DVT, arterial inflow is usually preserved, so the limb rarely becomes truly cyanotic unless there is extreme venous congestion. Option B, the affected leg is warmer than the other, may occur due to inflammatory changes in the vessel wall, but this is not as specific or reliable as unilateral swelling. It can accompany many other inflammatory or infectious conditions. Option C, indicating a capillary refill time of approximately 2 seconds, is within normal limits and assesses arterial perfusion rather than venous obstruction, making it unrelated to the pathologic process of DVT. Finally, Option D, noting swelling of the lower affected leg, is the correct and most diagnostic finding. This localized swelling directly reflects venous obstruction and fluid extravasation caused by the clot, making it the hallmark indicator of DVT in clinical assessment. Transitioning to the Stand-Coast Clinical Pearl, remember this vital nursing insight. Unilateral swelling and calf tenderness are the red flags of deep vein thrombosis. Always compare both legs for circumference, temperature, and skin color. Early recognition and prompt intervention can prevent a potentially fatal pulmonary embolism. Moving forward with the Stand-Coast high-yield NCLEX tip, keep this in mind. When deep vein thrombosis is suspected, never massage the limb or encourage mobility. Keep the leg elevated, maintain bed rest, and avoid compressive devices until diagnostic confirmation is obtained. Prepare the client for Doppler ultrasound or D-dimer testing and anticipate the initiation of anticoagulant therapy as prescribed. Shifting our focus to a client experiencing a vascular complication, picture this scenario carefully. A client has been diagnosed with thrombophlebitis after the nurse observed tenderness, warmth, and mild swelling along a superficial vein in the left leg. The nurse must now update the plan of care to ensure both safety and the prevention of further complications. The question asks, which modification is most appropriate to add to the client's care plan at this time? Here are the options to consider. Option A, ambulate the client twice each shift. Option B, refrain from massaging the client's legs. Option C, avoid elevating the client's legs. Option D, encourage the client to perform active leg exercises. The correct answer is Option B, refrain from massaging the client's legs. Digging deeper into this, when a client develops thrombophlebitis, it means that a thrombus has formed within an inflamed vein. This situation poses a serious risk that the clot may dislodge and travel through the bloodstream to the lungs, leading to a potentially fatal pulmonary embolism. Therefore, massaging the affected area is strictly contraindicated because even gentle manipulation can cause the clot to break free, move through the venous system, and block the pulmonary arteries. During the acute phase, activity is limited until anticoagulant therapy has been started and the risk of embolization decreases. Bed rest with the affected leg elevated around 20 to 30 degrees helps reduce swelling, promote venous return, and relieve discomfort. However, nurses must avoid placing pillows directly under the knees, as this can compress venous flow and worsen stasis. Once anticoagulation has taken effect and inflammation subsides, gradual ambulation under supervision may be safely resumed to prevent further thrombus formation by activating the calf muscle pump. The nurse must also remain vigilant for early signs of pulmonary embolism, such as sudden shortness of breath, chest pain, anxiety, tachycardia, or coughing up blood. Warm compresses can help soothe discomfort, and prescribed anticoagulants such as heparin or warfarin are essential in preventing clot extension and further complications. Turning to the incorrect options, Option A, ambulating the client twice each shift, is not suitable during the acute phase because movement may cause the clot to dislodge. Early ambulation is beneficial only once therapeutic anticoagulation is achieved and inflammation has decreased. Option C, avoiding leg elevation, is also incorrect, since elevation actually helps decrease venous congestion, reduce edema, and ease pain. Avoiding it would worsen these symptoms. Option D, encouraging active leg exercises, is inappropriate in confirmed thrombophlebitis because such exercises increase venous pressure, raising the risk of thrombus dislodgement. Transitioning into a high-yield insight from Stand-Coast Clinical Pearl, remember this. Never massage or manipulate an extremity with suspected thrombophlebitis. What might feel like providing relief could instead cause catastrophic embolization if the clot breaks loose. The priority is prevention through early mobilization, hydration, compression therapy, and anticoagulation. But once a clot has formed, all movement must be medically guided. Finally, moving on to an essential Stand-Coast high-yield NCLEX tip, always differentiate between prevention and management. While exercises, ambulation, and hydration help prevent thrombosis, in confirmed thrombophlebitis, nursing care focuses on restricting activity, elevating the leg, and closely monitoring for embolic symptoms. The most dangerous nursing error in this condition is massaging the affected limb. Transitioning into this clinical situation, imagine caring for a client diagnosed with thrombophlebitis who has been prescribed warm, moist compresses for the affected leg. The nurse now prepares to implement this treatment as part of the overall care plan, ensuring safety and therapeutic benefit. The question asks, which nursing action demonstrates the correct understanding of safe and effective application? The options provided are as follows. Option A, heating the water to 120 degrees Fahrenheit, 48.8 degrees Celsius, before soaking the compress. Option B, using sterile technique when applying the compress. Option C, inspecting the skin every 4 hours during treatment. Option D, covering the wet gauze with a dry towel and waterproof layer. The correct answer is Option D, covering the wet gauze with a dry towel and waterproof layer. Delving deeper into the reasoning behind this, warm, moist compresses are applied to enhance circulation, relieve discomfort, and support healing in clients with conditions such as thrombophlebitis or cellulitis. The correct method requires maintaining the temperature between 98 degrees Fahrenheit and 105 degrees Fahrenheit, 36.6 degrees Celsius to 40.5 degrees Celsius. Covering the moist gauze with a dry towel and waterproof layer is crucial because it conserves both heat and moisture, creating an effective therapeutic environment while preventing rapid cooling and evaporation. This practice also helps protect the client's bedding and clothing from moisture, promoting comfort and maintaining infection control. Skin safety is a key consideration. Nurses must assess the skin every 30 minutes for redness, blistering, or maceration, which are early signs of thermal injury. Each compress is typically applied for 15 to 30 minutes, repeated several times per day as prescribed. Additionally, the nurse should consistently evaluate the client's skin tolerance and comfort level throughout the procedure. Using sterile technique is not required for intact skin. A clean approach is sufficient unless there are open wounds or drainage. On the other hand, water heated to 120 degrees Fahrenheit, 48.8 degrees Celsius, can cause burns and tissue damage, particularly in elderly clients or those with impaired sensation or circulation. Likewise, inspecting the skin every 4 hours is far too infrequent and could result in missing early warning signs of injury. Therefore, the safest and most effective nursing action is to cover the wet gauze with a dry towel and waterproof layer to maintain consistent warmth, retain moisture, and ensure patient safety. Transitioning to a vital learning takeaway. Here comes your Stan Coast clinical pearl. Warm, moist compresses are healing only when used wisely. Gentle warmth promotes blood flow, but excessive heat destroys tissues. Always remember, comfort, coverage, and continuous skin checks. Moving into your Stan Coast high-yield NCLEX. Tip: every time you apply heat or cold therapy, remember the golden trio. Temperature, time, and tissue condition. Temperature: maintain between 98 degrees Fahrenheit and 105 degrees Fahrenheit, never exceeding 105 degrees Fahrenheit. Time: keep sessions within 15 to 30 minutes. Tissue: continuously monitor for redness, blistering, or pallor. Here is the final takeaway. Heat relaxes, cold constricts. So, for venous inflammation such as thrombophlebitis, choose warm, moist therapy. For acute swelling or injury, cold compresses are the better option. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Moving further into this clinical care discussion, imagine you are attending to a client diagnosed with deep vein thrombosis who has been prescribed heparin sodium. During medication teaching, the client curiously asks, "Why has the physician prescribed this medication for me?" The nurse must respond with the most accurate explanation that reflects a clear understanding of heparin's therapeutic role. The options provided are as follows. Option A states, heparin helps shrink the blood clots that are already formed. Option B says, heparin dissolves existing clots and restores normal circulation. Option C explains, heparin prevents additional clots from forming and existing ones from growing larger. Option D mentions, heparin keeps the current clot from dislodging and traveling to the lungs. The correct answer is option C, which states that heparin prevents additional clots from forming and existing ones from growing larger. Delving deeper into the rationale, heparin is a parenteral anticoagulant that works by inhibiting the conversion of fibrinogen to fibrin, thereby preventing clot formation and further propagation of existing thrombi. It enhances the action of antithrombin 3, which in turn neutralizes several clotting factors, especially thrombin factor 2A and factor XA, effectively slowing the coagulation process. However, heparin does not dissolve already formed clots. Rather, it stabilizes them and allows the body's natural fibrinolytic system to gradually break them down over time. In conditions such as deep vein thrombosis, pulmonary embolism, myocardial infarction, or atrial fibrillation, the goal is primarily to prevent clot enlargement or recurrence, not dissolution. Thrombolytic drugs like alteplase, TPA, streptokinase, and urokinase are reserved for dissolving existing clots but come with a high bleeding risk and are used under close monitoring in critical cases. Therefore, while educating clients, nurses must emphasize that heparin's purpose is preventive. It keeps the situation from worsening rather than reversing it instantly. Exploring the incorrect options, option A, heparin helps shrink the blood clots that are already formed, is inaccurate because heparin has no fibrinolytic action and cannot reduce the size of existing clots. That function is exclusive to thrombolytic agents such as TPA or streptokinase. Option B, heparin dissolves existing clots and restores normal circulation, is also incorrect since this describes the mechanism of thrombolytics, not anticoagulants. Heparin prevents further clotting but does not restore normal circulation immediately by dissolving thrombi. Lastly, option D, heparin keeps the current clot from dislodging, is incorrect because clot mobility depends on hemodynamic forces, not the medication. Preventing embolization relies more on limb elevation, immobilization, and avoiding pressure or massage over the affected area rather than pharmacologic intervention. Transitioning into the clinical highlight, Stan Coast Clinical Pearl emphasizes that heparin holds the line, not breaks it. It keeps clots from marching forward but never sends them back. This means the drug's action is purely preventive, ensuring stability and safety while the body's natural mechanisms take over the healing process. Continuing with a key exam takeaway, Stan Coast High Yield NCLEX. Tip reminds you to differentiate these drug categories easily. Heparin prevents clot formation and works immediately when administered intravenously. Warfarin prevents future clots and requires 3 to 5 days to reach therapeutic effect. Thrombolytics dissolve existing clots directly, but carry a high risk of bleeding. Moving onward into another critical nursing concept, picture this scenario. A nurse is preparing to administer a prescribed subcutaneous dose of heparin sodium to a client who has been diagnosed with deep vein thrombosis. Before giving the medication, the nurse reviews the laboratory results and must determine which finding requires immediate notification of the physician. The available options are as follows. Option A, partial thromboplastin, time PTT. Option B, complete blood count, CBC. Option C, hemoglobin, HB. Option D, prothrombin, time PT. The correct answer is option A, partial thromboplastin time, PTT. Diving deeper into the rationale, heparin sodium functions as an anticoagulant by enhancing the activity of antithrombin 3, which inactivates thrombin and factor SAW. This action inhibits the conversion of fibrinogen to fibrin, thereby preventing the formation of new clots and stopping the extension of existing ones. Because heparin acts on the intrinsic and common pathways of the coagulation cascade, the most accurate laboratory test for monitoring its therapeutic effect is the activated partial thromboplastin time, or a PTT. The therapeutic range is generally 1.5 to 2.5 times the normal control value, approximately 45 to 80 seconds, depending on institutional standards. A value exceeding this range signals an excessive anticoagulant effect and heightened bleeding risk, necessitating the dose to be withheld and reported to the physician. On the other hand, a low APTT suggests that heparin is not effective in preventing clot propagation. Therefore, Nurses must always review the most recent APTT results before each administration. Now, let us clarify why the other options are not correct. Option B, complete blood count, CBC, helps assess platelet count and detect possible heparin-induced thrombocytopenia, HIT, but it is not the main test used to measure heparin's anticoagulant activity. Option C, hemoglobin, HB, reflects oxygen carrying capacity and may reveal anemia or bleeding, but it is unrelated to heparin's mechanism of action. Option D, prothrombin. Time, PT, evaluates the extrinsic pathway and is used for clients on warfarin therapy, not for those receiving heparin. Since heparin and warfarin affect different coagulation pathways, PT or INR does not apply to heparin monitoring. Transitioning now to an important memory cue from Stan Coast Clinical Pearl, remember this: heparin affects the intrinsic pathway. Think heparin in the hospital. Warfarin affects the extrinsic pathway. Think warfarin out for discharge. Always check a PTT before heparin and INR before warfarin. Okay, before we wrap up, here's your Stan Coast high-yield NCLEX tip. Something you should definitely keep in mind for your next exam. Let's quickly go over some important drugs and what you need to monitor for each. First, heparin. Remember, we monitor the APTT. The therapeutic range should be about 1.5 to 2.5 times the control. If it's prolonged, you should hold the medication and report it. Next, warfarin. This one's monitored using PT or INR. The therapeutic INR range is between 2 and 3, and here's your key nursing reminder. Always teach your patient about foods rich in vitamin K, since those can affect the drug's effectiveness. And finally, enoxaparin, also known as low molecular weight heparin. For this, we check the anti-XA level, but only as per protocol. Usually there's no need for routine APTT monitoring with this drug. So keep this short list in your head: heparin, warfarin, and enoxaparin. And remember what to monitor for each. It's one of those quick NCLEX points that can easily show up on your test. Before we move on to the next NCLEX topic, let me share something that could be the game changer in your journey. If you are determined to pass the NCLEX on your very next attempt, the Ultimate NCLEX Crash Course is exactly what you need. This program has already helped more than 100,000 nursing students achieve success. And now it's your turn. Here is what makes it powerful: daily interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks and PDF notes for quick revision, a ready-to-use student planner, and detailed NGN question breakdowns in comprehensive lectures. It is not just a course, it's your all-in-one NCLEX toolkit. Simply scan the QR code now or click the link in the description to enroll instantly. You'll unlock free content like PDF notes, practice tests, and NCLEX quizzes, plus access to our Telegram and WhatsApp groups filled with even more free resources to keep you ahead. Moving forward into an essential medication safety concept, picture this scenario. The nurse is about to withdraw a prescribed dose of heparin sodium from a multi-dose vial. Accuracy, sterility, and correct technique are all critical to ensure patient safety. The question asks, which nursing action demonstrates the correct method of withdrawal? The options provided are as follows. Option A suggests removing the rubber stopper before withdrawing the solution. Option B recommends instilling an equal volume of air into the vial as the amount of fluid to be withdrawn. Option C advises mixing the drug by rolling the vial between the palms before drawing it up. And Option D proposes shaking the vial vigorously to ensure even distribution of the drug. The correct answer is Option B. Instill an equal volume of air into the vial as the amount of fluid to be withdrawn. Delving deeper into the rationale, this technique maintains pressure equilibrium within the vial, which is essential for smooth and accurate medication withdrawal. By injecting air equal to the desired volume of liquid, the nurse counteracts the negative pressure created inside the vial, preventing vacuum resistance and allowing effortless aspiration of the medication. If air is not introduced, the resulting vacuum makes it difficult to draw up the solution, leading to inaccurate dosing or air bubbles in the syringe. On the other hand, injecting too much air can force the solution to surge into the syringe, potentially contaminating the needle or even dislodging the plunger, both of which are unsafe outcomes. Now, analyzing why the other options are incorrect provides additional clarity. Option A, removing the rubber stopper, compromises sterility and exposes the medication to environmental contaminants, making it an unsafe practice. Option C, rolling the vial between the palms, applies only to medications that require gentle mixing, such as modified insulin preparations, not heparin sodium, which is a clear solution. Option D, shaking the vial vigorously, may introduce air bubbles and alter the integrity of delicate biological solutions, rendering this approach incorrect and unsafe. Transitioning to an important professional insight, here comes the Stancoast Clinical Pearl. Always remember, air in equals fluid out. Introducing an equal volume of air before withdrawal prevents vacuum resistance and ensures accurate dosage delivery. Finally, concluding with a key examination insight, the Stancoast High-Yield NCLEX. Tip: when preparing heparin, maintain strict aseptic technique, never remove the stopper, and avoid shaking. Since heparin is a high-alert medication, always double-check the dose and concentration before administration. A single error or contamination can lead to serious complications such as overdose or infection. Moving onward to a vital medication safety scenario, imagine the nurse preparing to administer a prescribed dose of heparin sodium subcutaneously to an adult client with an average weight and height. The question asks which nursing action demonstrates correct technique for this injection. The options are as follows. Option A suggests selecting the dorsogluteal site for injection. Option B recommends using a 22-gauge, 1.5-inch needle. Option C involves inserting the needle at a 45-degree angle to the skin. And Option D advises massaging the site immediately after the injection. The correct answer is Option C, inserting the needle at a 45-degree angle to the skin. To elaborate, when giving a subcutaneous injection such as heparin sodium, it is crucial for the nurse to adjust the injection angle and site based on the client's body composition. This ensures that the medication is properly deposited into the fatty tissue below the dermis, instead of being injected into muscle or skin layers. For a client of average weight, inserting the needle at a 45-degree angle allows just the right depth for subcutaneous administration. In contrast, obese clients require a 90-degree angle due to thicker adipose tissue, while very thin clients may need an angle between 30 and 45 degrees. Heparin is a high-alert anticoagulant medication, and accuracy in administration is critical to prevent bleeding complications. The appropriate sites for injection are areas with sufficient adipose tissue such as the abdomen, keeping at least 2 inches away from the umbilicus, the upper arms, or the anterior thighs. Sites showing bruising, scars, or inflammation must be avoided. Option A, which involves selecting the dorsogluteal site, is incorrect because this site is used primarily for intramuscular injections and poses a risk of sciatic nerve injury. Option B, using a 22-gauge, 1.5-inch needle, is also inappropriate since that size is intended for intramuscular injections. Subcutaneous injections require a much smaller needle, typically 25 to 26 gauge and 3/8 to 5/8 inch in length. Finally, Option D, massaging the site after injection, is contraindicated because heparin alters clotting time, and rubbing the site can lead to bruising, hematoma formation, and tissue damage. Instead, the nurse should gently apply dry gauze if bleeding occurs while maintaining strict aseptic technique throughout the procedure. Moving to the Stancoast Clinical Pearl, remember this key principle. Subcutaneous injection is all about precision and pressure balance. Right site, right angle, right depth. Never massage a heparin site. Let the medication diffuse naturally to prevent bruising and bleeding. Transitioning to the Stancoast High-Yield NCLEX. Tip: always recall this SMART formula. The injection angle depends on fat depth. For thin or average clients, use a 45-degree angle. For obese clients, use a 90-degree angle. Additionally, rotate injection sites regularly, avoid aspiration, and never massage after administering anticoagulants like heparin or enoxaparin to minimize the risk of tissue trauma and hematoma formation. Moving into another critical anticoagulation scenario, imagine a post-operative client who has been receiving daily subcutaneous heparin sodium injections for several days and suddenly reports new symptoms. The question asks which assessment findings should be reported immediately to the healthcare provider. The available options are as follows. Option A states localized abdominal tenderness at the injection site. Option B mentions tiny bruises and mild redness at the injection sites. Option C identifies bleeding of gums after toothbrushing. And Option D describes soft, light brown stools. The correct answer is Option C, bleeding of gums after toothbrushing. Let us analyze this carefully. In clients receiving heparin therapy, The nurse must be alert for signs of systemic bleeding because heparin works by enhancing the effect of antithrombin 3, which in turn inhibits thrombin and factor XA, effectively preventing clot formation. However, this anticoagulant action can sometimes go too far, leading to excessive bleeding. Bleeding gums after brushing the teeth represent one of the earliest signs of systemic anticoagulant toxicity. This happens because the oral mucosal capillaries are fragile and rupture easily when clotting factors are suppressed. If unnoticed, these minor signs can progress into life-threatening complications like nosebleeds, hematuria, hematemesis, melena, or even intracranial bleeding. Hence, this finding must be reported immediately to the healthcare provider for further evaluation of the heparin dosage, possible discontinuation, and diagnostic assessment of coagulation studies such as activated partial thromboplastin, time APTT. In contrast, option A, localized abdominal tenderness, is an expected reaction caused by repeated subcutaneous injections that may irritate the tissue. It can be managed by rotating sites and avoiding massaging, which helps prevent hematoma formation. Option B, tiny bruises or petechiae at injection sites, are also common due to minor capillary trauma, and do not usually indicate systemic bleeding unless widespread. Lastly, option D, soft light brown stools, are normal findings and do not raise concern. What would be alarming instead are dark, tarry stools, which suggest gastrointestinal bleeding. Now transitioning into a quick takeaway, Stand-Coast Clinical Pearl. Even a drop of unexpected bleeding in a client on heparin is a red flag. Gums, urine, or stool color can be the earliest warning signs of internal hemorrhage. Always assess first, then report without delay. And to reinforce your memory, Stand-Coast High Yield NCLEX. Tip. Use this simple mnemonic BLEED to remember key bleeding indicators in heparin therapy: bleeding gums, low platelets, heparin-induced thrombocytopenia, easy bruising, epistaxis, and dark stools. If any of these are noted, stop heparin, assess a PTT, and notify the provider without hesitation. Let us dive into a vital anticoagulation concept that every nurse must master during post-operative care. Picture this scenario. A client who recently underwent surgery is on a continuous intravenous heparin infusion to prevent deep vein thrombosis. During your shift, you notice that the client's activated partial thromboplastin time, or a PTT, has risen to 115 seconds, accompanied by minor gum bleeding. The healthcare provider immediately instructs you to prepare the antidote for heparin toxicity. The question now is, which medication should the nurse anticipate administering to counteract the effects of heparin therapy? The available options are option A, calcium lactate, option B, sodium benzoate, option C, protamine sulfate, and option D, aluminum phosphate. The correct answer is option C, protamine sulfate. Now let us unpack the clinical reasoning behind this. When caring for a client receiving heparin, it is essential to continuously monitor coagulation parameters, especially the APTT level. The therapeutic goal for a PTT in clients on heparin therapy is typically between 1.5 to 2.5 times the normal control value, which usually translates to 60 to 80 seconds. When the APTT climbs to 115 seconds, this signals excessive anticoagulation and a high risk for bleeding complications, which may present as nosebleeds, bleeding gums, hematuria, or even gastrointestinal bleeding. Protamine sulfate is the specific antidote that directly neutralizes heparin. It achieves this by binding to heparin and forming a stable inactive complex, effectively reversing its anticoagulant action almost instantly. For dosing, each milligram of protamine sulfate neutralizes about 100 units of heparin, but the exact dose depends on the amount of heparin administered and the timing since the last dose. It is crucial to administer this medication slowly through the intravenous route, typically over 10 minutes, to avoid potential adverse effects such as hypotension, bradycardia, or anaphylactoid reactions. These side effects are more likely in clients with fish allergies or those who have had a vasectomy. In contrast, calcium lactate is simply a calcium supplement that treats hypocalcemia but has no effect on heparin. Sodium benzoate is commonly used as a preservative in foods and medications and plays no role in reversing anticoagulation. Aluminum phosphate, on the other hand, is an antacid that reduces stomach acid levels but does not affect heparin's mechanism of action. Transitioning into the most crucial takeaway from this case, we arrive at the Stand-Coast Clinical Pearl, which reminds us that when heparin runs too long or too strong, protamine sulfate steps in to make it right, bind, neutralize, and restore clotting balance. Moving further into exam mastery, here comes the Stand-Coast High-Yield NCLEX tip, where you can use the mnemonic HEPARIN, which stands for Heparin Effects Prevented and Reversed, instantly with neutralizer, protamine sulfate. Always keep in mind, heparin equals protamine, warfarin equals vitamin K. Moving on to another essential clinical concept in nursing practice, imagine a nurse administering a subcutaneous injection of heparin to a post-operative client who is receiving anticoagulant therapy. After withdrawing the needle, the nurse applies firm, prolonged pressure to the injection site for several minutes without massaging it. The question asks which of the following best describes the nurse's action. Here are the options to consider. Option A states that the nurse's action is inappropriate because prolonged pressure promotes hematoma formation. Option B suggests that the nurse's action is inappropriate because it delays drug absorption. Option C claims that the nurse's action is correct because it helps evenly distribute the drug within the tissue. Option D indicates that the nurse's action is correct because it minimizes bleeding and tissue bruising. The correct answer is Option D. The nurse's action is correct because it minimizes bleeding and tissue bruising. Now, let us analyze this more deeply. This question highlights a key nursing principle: safe injection technique in clients receiving anticoagulant therapy, such as heparin. When administering subcutaneous heparin, the nurse must take precautions to reduce local bleeding and prevent hematoma formation because of the drug's strong anticoagulant effects. Applying firm pressure with a gauze pad after removing the needle helps seal small blood vessels and prevents oozing of blood into the surrounding tissue. However, the nurse must never massage the site, as that action can cause tissue trauma, uneven drug dispersion, and bruising. Heparin works by enhancing the activity of antithrombin 3, which inhibits thrombin and factor XA, thus slowing the clotting process. Since this decreases the body's ability to form clots, even minimal trauma at the injection site can lead to visible bruising or bleeding. Applying firm pressure for a few minutes helps achieve hemostasis without affecting the rate of absorption, since heparin's absorption is naturally slow and steady through the subcutaneous tissue. If adequate pressure is not maintained, blood can pool under the skin and create a hematoma, which not only causes discomfort, but also limits future injection sites and increases infection risk. Therefore, applying firm, prolonged pressure after heparin administration is an evidence-based nursing action that promotes client safety and prevents complications. To clarify the incorrect options, Option A is incorrect because prolonged pressure does not cause hematoma formation. It prevents it. The real cause of a hematoma is inadequate pressure that allows blood to seep into surrounding tissue. Option B is also incorrect because applying pressure does not delay absorption. Heparin is absorbed slowly by design through the subcutaneous route. Option C is incorrect because the purpose of applying pressure is not to distribute the drug but to stop bleeding. Heparin should stay localized in the subcutaneous tissue for controlled absorption. Rubbing or massaging spreads it unnecessarily and increases bruising risk. And speaking of clinical wisdom, here comes the Stand-Coast clinical pearl. When giving heparin, press but never rub. Gentle, firm pressure prevents bleeding without forcing the drug into the tissue, protecting both your client's safety and the integrity of the injection site. Now moving to the Stand-Coast High-Yield NCLEX tip, remember the 4 golden rules for heparin injection. 1. Use a 25 to 27 gauge, 5/8 inch needle for subcutaneous administration. 2. Always inject into the abdomen, at least 2 inches away from the umbilicus. 3. Never aspirate or massage after injection. 4. Apply firm pressure for 1 to 2 minutes to minimize bleeding. Continuing our journey through essential NCLEX pharmacology concepts, let us explore a crucial discharge teaching scenario involving anticoagulant therapy. A nurse is preparing discharge instructions for a client who will continue taking warfarin, also known as Coumadin, at home after treatment for deep vein thrombosis. The nurse asks the client to repeat back what they have understood about bleeding precautions related to this medication. Here are the options to consider. Option A says, I will need to report if my urine becomes dark amber in color. Option B states, I must immediately report if my stools become black or tar-colored. Option C mentions, I will call the healthcare provider if my vomit looks greenish or yellow. Option D declares, I should notify the healthcare provider if my skin starts turning yellow. The correct answer is option B. I must immediately report if my stools become black or tar-colored. Let us now understand why this answer is correct. This question tests the nurse's ability to determine whether the client understands the risks of bleeding associated with anticoagulant therapy, a key nursing responsibility in ensuring safe medication management. Warfarin works by inhibiting the synthesis of vitamin K-dependent clotting factors, which prolongs clotting time and prevents further thrombus formation. However, this same mechanism increases the risk of internal bleeding, which can be subtle yet life-threatening if not promptly recognized. Black, sticky, tar-like stools, clinically referred to as melena, are a hallmark of upper gastrointestinal bleeding. The dark coloration occurs when blood is digested and oxidized as it moves through the gastrointestinal tract, commonly indicating bleeding in the stomach or duodenum. In clients on warfarin, this symptom often suggests excessive anticoagulation or an elevated international normalized ratio, INR, which requires urgent medical assessment. In contrast, dark amber urine, as mentioned in option A, typically suggests dehydration or concentrated urine rather than bleeding. If urinary bleeding occurred, the color would more likely be pink, red, or cola-colored. Meanwhile, greenish vomit from option C points to bile reflux or intestinal obstruction, not bleeding. In true upper gastrointestinal bleeding, the vomitus appears like coffee grounds, dark and granular, due to partially digested blood. Lastly, jaundice, described in option D, reflects liver dysfunction or bile duct obstruction, not active bleeding. Although warfarin is metabolized by the liver, jaundice would not be the primary indicator of bleeding risk. Clients taking long-term warfarin must be educated to maintain consistent intake of vitamin K-rich foods, avoid excessive alcohol consumption, and promptly report any signs of abnormal bleeding, such as gum bleeding, nosebleeds, heavy menstrual flow, easy bruising, or prolonged bleeding from minor cuts. Regular INR testing is essential, with most therapeutic ranges maintained between 2.0 and 3.0. A higher value indicates excessive anticoagulation and bleeding risk, whereas a lower value suggests insufficient anticoagulation and potential clot formation. Moving toward a key clinical insight, Stancoast Clinical Pearl. Warfarin's safety lies in balance. Monitor the INR, maintain steady vitamin K intake, and report all signs of hidden bleeding, especially black terry stools or coffee ground vomit. And to reinforce your exam readiness, Stancoast High Yield NCLEX. Tip: remember the BBB rule for bleeding on blood thinners. Black stools, bruising, and bleeding gums must always be reported immediately. Additional red flags include pink urine, recurrent nosebleeds, or dizziness, all of which could point to internal bleeding and the onset of hypovolemia. Moving into another crucial NCLEX-style scenario, let us focus on an important discharge teaching moment that tests your knowledge of pharmacologic safety and patient education. A client who has been prescribed warfarin, also known as Coumadin, for long-term anticoagulation following a deep vein thrombosis, is preparing for discharge. The client asks the nurse if it is safe to resume taking over-the-counter herbal supplements and dietary enhancers that were used prior to hospitalization. The question is, which of the following supplements are most likely to alter the client's international normalized ratio, INR, and prothrombin time, PT? Here are the options to consider. Option A is ginkgo. Option B is St. John's wort. Option C is willow bark. Option D is ginger. Option E is green tea. Option F is creatine. The correct answers are options A, B, C, and D. Now let us understand the expanded rationale behind this answer. This question evaluates the nurse's understanding of herbal drug interactions and their effects on coagulation, which is a high-priority NCLEX concept under pharmacologic safety and medication education. Clients taking warfarin are at significant risk of life-threatening hemorrhage if any supplement interferes with hepatic metabolism or platelet function. To start with, ginkgo is a correct choice because it interferes with platelet-activating factors and enhances bleeding risk by inhibiting platelet aggregation. When combined with warfarin, it can potentiate anticoagulation and increase the INR, predisposing the client to intracranial or gastrointestinal bleeding. Nurses should teach clients to discontinue ginkgo at least 2 weeks before any surgical or invasive procedure. Moving on, St. John's wort is another correct option. This herbal supplement induces hepatic cytochrome P450 enzymes, which accelerate the metabolism of warfarin, causing a decrease in INR levels. The danger here is reduced anticoagulant efficacy, which increases the risk of thrombosis or stroke. Therefore, the nurse must educate clients that herbal stimulants like St. John's wort should never be used without physician supervision. Next, willow bark is also correct. It contains salicylates, compounds similar to aspirin, and exerts an additive antiplatelet effect when taken with warfarin. This greatly elevates the risk of mucosal or gastrointestinal bleeding. Clients must avoid any herbal supplement with aspirin-like properties while undergoing anticoagulation therapy. Furthermore, ginger is another correct response. It enhances fibrinolysis and reduces platelet stickiness, thereby increasing the anticoagulant effect of warfarin. Even small amounts of ginger in teas or food may elevate INR, especially in older adults or those with low body weight. Nurses should highlight the importance of moderation and consistent INR monitoring if the client insists on consuming ginger in their diet. However, green tea is incorrect because it is rich in vitamin K, which can reduce the anticoagulant effect of warfarin by promoting clotting factor synthesis. While excessive intake may lower INR, moderate and consistent consumption is generally safe. Sudden dietary changes involving green tea should always be avoided to maintain stable INR levels. Lastly, creatine is also incorrect. Although it is a popular supplement for enhancing muscle mass, it does not affect hepatic metabolism or coagulation pathways. However, clients with renal or cardiac issues should use it cautiously, as it may lead to fluid retention or kidney strain. Before we conclude, here comes the Stan Coast Clinical Pearl. Herbal supplements are not always harmless. Many act as silent modifiers of liver enzymes and platelets. The safest rule for clients on warfarin is simple. When in doubt, leave it out. Every supplement should be verified with a healthcare provider before use to prevent dangerous drug interactions. And finally, here is the Stan Coast High Yield NCLEX. Tip: remember this easy-to-recall formula. 4 G's bleed. Ginkgo, garlic, ginseng, and ginger all increase the risk of bleeding when taken with warfarin. In contrast, St. John's wort does the opposite by lowering INR through hepatic enzyme induction. This distinction is vital to safe patient teaching and exam success. Let us move ahead into a real-world nursing situation that challenges your ability to think critically about patient safety and intravenous care. A nurse is assessing a client receiving an intravenous infusion of normal saline and notices redness, warmth, and tenderness along the vein. The site also has a palpable cord and mild edema. So, what should the nurse do first in this scenario? Here are the options to consider. Option A is to elevate the affected extremity on pillows to promote venous return. Option B suggests applying firm pressure over the IV site to reduce swelling. Option C proposes increasing the IV flow rate to prevent clot formation. Option D recommends discontinuing the IV infusion and removing the catheter immediately. The correct answer is Option D. Discontinue the IV infusion and remove the catheter immediately. Now, let us unpack the reasoning behind this. This question highlights a nurse's clinical judgment in managing complications related to intravenous therapy, specifically phlebitis, which is the inflammation of a vein caused by mechanical irritation, chemical damage, or infection. The key signs, redness, warmth, tenderness, and a palpable cord, indicate that the vein's inner lining is inflamed. Continuing the infusion in such a case could worsen the injury, lead to thrombus formation, or even result in systemic infection. Therefore, the nurse's top priority is to stop the infusion and remove the catheter immediately to halt further endothelial damage. After removal, applying a warm compress helps promote comfort and circulation. The nurse should also document findings and restart the infusion in a new site, preferably in another extremity. While elevating the extremity may later relieve discomfort and swelling, it is not the first intervention. Applying pressure is contraindicated because it can aggravate vein irritation, and increasing the flow rate would worsen inflammation, violating the fundamental principle of stop the source first whenever a complication arises in intravenous therapy. According to Infusion Nurses Society, INS standards, intravenous sites should be rotated every 72 to 96 hours or sooner if complications develop. Preventive measures include proper vein selection, securement, and using compatible solutions. Transitioning now to a deeper perspective, here is the Stand-Coast clinical insight. Whenever redness or tenderness appears at an IV site, think remove, relieve, and restart, not rate up or wrap tight. The nurse's priority is always to stop the cause, not just manage the symptom. And moving on to Stand-Coast High-Yield NCLEX Pearl. An easy way to remember this is with the mnemonic RED. Remove early, don't delay. R stands for redness or warmth. Suspect phlebitis. E reminds you to end the infusion immediately. D emphasizes document, apply a warm compress, and restart at a new site. Phlebitis is graded from 0 to 4 in severity. A grade of 2 or higher always requires immediate discontinuation of the line. It can be mechanical, caused by catheter movement, chemical, from irritant solutions such as potassium chloride or vancomycin, or bacterial, from microbial contamination. Recognizing these distinctions and acting promptly ensures patient safety and demonstrates high-level critical thinking, exactly the kind of judgment expected on the NCLEX. Moving deeper into infusion therapy, let us consider a scenario that tests your clinical observation and judgment. A post-operative client has been receiving intravenous fluids through the same peripheral site for several days. During routine assessment, the nurse notices new discomfort and visible changes at the insertion site. The question asks which finding most strongly suggests that the client is developing phlebitis, rather than another infusion-related complication. Here are the options. Option A states that the vein is red, warm, and tender along its path. Option B indicates that the vein appears dark and feels cool to the touch. Option C describes the vein as pale and hard with a cool temperature. Option D explains that the vein looks purplish and feels spongy when palpated. The correct answer is Option A. The vein is red, warm, and tender along its path. When we explore the reasoning behind this, phlebitis is an inflammatory reaction of the vein wall that typically results from mechanical irritation such as catheter movement, chemical irritation from hypertonic or acidic solutions, or bacterial contamination. Early signs include tenderness and mild discomfort at the site, soon followed by redness, warmth, and a palpable cord-like vein. As the inflammation progresses, there may be mild edema and a slower flow rate. If not addressed promptly, this condition can advance to thrombophlebitis, where inflammation is accompanied by clot formation, greatly increasing the risk of embolism. The nurse's response must include stopping the infusion immediately, documenting the findings of redness, warmth, tenderness, and cord-like vein, and starting a new intravenous line on the opposite extremity. The affected limb should be elevated, and warm compresses should be applied to promote comfort and circulation. Let us now distinguish why the other options do not fit. Option B, describing a dark, cool vein, suggests infiltration or extravasation, where the fluid leaks into surrounding tissue due to catheter displacement. The coolness occurs because the infusing solution seeps into the interstitial space, and the site often appears pale or swollen, not warm or inflamed. Option C, a pale and hard vein that feels cool, also indicates infiltration or occlusion, not phlebitis. The hardness comes from fluid pressure beneath the skin rather than vein inflammation. Option D, a purplish and spongy vein, is typical of a hematoma caused by local bleeding under the skin from trauma or improper removal technique. This presentation includes bruising and tenderness, but lacks the heat and firmness that characterize phlebitis. Transitioning into the clinical perspective, here comes the Stand-Coast clinical insight. Phlebitis can be remembered by the 3 R's: redness, radiating warmth, and rope-like vein. The nurse should always inspect and palpate both arms to detect early changes. Early recognition not only prevents pain and discomfort, but also stops complications like thrombosis and infection before they escalate. Moving further into examination wisdom, the Stand-Coast High-Yield NCLEX Pearl teaches us how to differentiate infusion-related complications effectively. Phlebitis equals warm plus red plus painful plus cord-like. Infiltration equals cool plus swollen plus pale plus slow flow. Hematoma equals purplish plus tender plus soft or spongy. Infection equals red plus pus plus fever or systemic signs. These visual and tactile distinctions are life-saving in clinical settings and frequently appear on the NCLEX. Recognizing subtle differences between these findings allows nurses to act promptly, ensuring both patient safety and examination success. Moving ahead into the topic of anticoagulation management, Imagine you are teaching a client who has been prescribed Warfarin for long-term therapy. In this teaching session, the nurse must stress the importance of consistency in dietary habits, particularly regarding foods rich in vitamin K, since excessive or fluctuating intake can interfere with Warfarin's action. The question asks which of the following foods should the client limit in their diet. The options provided are A. Fresh spinach, B. Lettuce, C. Turnip greens, D. Brussels sprouts, E. Peas, and F. Corn. The correct answers are A, B, C, and D. Fresh spinach, lettuce, turnip greens, and Brussels sprouts. Now, let us understand the scientific reasoning behind this. Warfarin works by inhibiting the synthesis of vitamin K-dependent clotting factors 2, 7, 9, and 10 in the liver. The drug's therapeutic effect is highly sensitive to the amount of vitamin K consumed in the diet. When vitamin K intake increases, Warfarin's effect decreases, leading to possible clot formation. Conversely, if vitamin K intake drops sharply, the drug's anticoagulant effect can become excessive, leading to bleeding. Hence, clients are not advised to completely avoid vitamin K-rich foods, but to maintain a consistent daily intake so that the dosage of Warfarin can be adjusted accurately according to their International Normalized Ratio, INR. Looking at each food choice in detail, fresh spinach is correct because it contains one of the highest levels of vitamin K, more than 400 micrograms in just half a cup of cooked spinach. Inconsistent intake can make INR levels fluctuate and reduce Warfarin's effectiveness. Lettuce is also correct, especially the green leafy types like romaine or green leaf lettuce, which contain significant vitamin K. Turnip greens are another correct choice, being extremely high in vitamin K. Large or irregular consumption can reverse the drug's intended anticoagulation. Similarly, Brussels sprouts are rich in vitamin K and can alter INR levels if consumed inconsistently. On the other hand, peas are incorrect because they have minimal vitamin K content and are generally safe. Corn is also incorrect since it has negligible amounts of vitamin K and does not influence Warfarin metabolism. From a clinical teaching standpoint, nurses must emphasize that clients on Warfarin should focus on dietary consistency rather than total avoidance. The nurse should review the therapeutic INR range, typically between 2 and 3, and highlight the need for regular INR monitoring. If a client suddenly increases green vegetable consumption, INR may drop, leading to clot risk, whereas reducing it drastically can cause INR to rise, resulting in bleeding tendencies. It is equally crucial to discuss herbal and drug interactions, particularly the 4 Gs, ginkgo, garlic, ginseng, and ginger, which can increase bleeding risk, as well as antibiotics or aspirin that may alter Warfarin's metabolism. Transitioning to a key takeaway for clinical practice, stand coast. Clinical pearl. Warfarin and vitamin K are like a seesaw. When one rises, the other falls. Keeping intake balance is the secret to maintaining a stable INR. And to make this even easier for exam memory, stand coast high-yield NCLEX pearl. Remember the 4 Gs that increase bleeding risk with Warfarin, garlic, ginseng, ginkgo, and ginger. Also, remember the 4 Gs of greens that counteract Warfarin: green spinach, green lettuce, green turnip tops, and green Brussels sprouts. Thank you so much for watching this video. If you found it helpful, don't forget to like, share, and subscribe.